Hello, everyone. Welcome to Mom's Corner. My name is Zainab. I hope everyone's doing well today. And thank you so much for being here. For those of you who are regulars for Mom's Corner, thank you so much for your loyalty and for showing up for every session. And for those who are joining us for the first time today, welcome. And I hope that we will see you for future sessions. And a huge shout out and thank you to our amazing doctors today for being here. Our topic for today is female reproductive health conditions. And I just wanted to give a little backdrop introduction of Mom's Corner. Mom's Corner is one of the many programs under the umbrella of Global Perinatal Services, or GPS, and it's so hard to focus with that cute cat, Dr. Chen. Um, but yes, GPS is a nonprofit organization doing some amazing work and changing lives every day. Our mission is to create culturally responsive pregnancy and parenting experiences for Black immigrant and refugee families. We provide perinatal support services that include doula services, lactation education, childbirth education, early parenting support, and child development. And the communities that we provide those services to include marginalized communities, which include Black immigrant and refugee families, as I mentioned. And Mom's Corner, for those of you who have been here from the beginning, is not just a space for moms, but for all women folk and supporters of women. And at GPS, we believe that motherhood is an extension of women's identity and not the definition. And since the pandemic, really, the Mom's Corner has become not just a space where we come together to find empathy, support, and camaraderie, but a safe haven and access to so many critical resources in our communities. I just want to mention that we will have a Q&A session at the end of the presentation, but if you should have any questions or comments today, we really encourage all forms of participation. Please feel free to participate any way you are able to. Do it by submitting your questions to me privately through the chat box or just using the emoji features on your screen. And don't be shy. This is a community space, so it's judgment-free zone and all questions are welcomed and encouraged. So please keep in mind that the information provided in this session today is for educational purposes only and should not be used as a substitute for professional medical advice, diagnosis, and treatment. And we encourage you to consult with your healthcare provider for any personal medical concerns you may have. And so without further ado, I will hand it over to our amazing doctors. Thank you for being here today.
Hi, everyone. I'm Wendy, and Shireen and Rebecca and I are all First Hill Family Medicine residents, and we're so excited to be here. I am just going to share my screen really quickly. Sorry, it just is not letting me share it for some reason.
Zainab, I think it's telling us we need to request sharing.
I have the ability to share. My computer is not letting me share. I don't know if we can give it to one of
Okay, I can do that.
too.
So is that requested? Yeah, Dr. Shireen.
I just send the request.
Yep,
I can
accept it.
Perfect.
Yes.
Sorry, we should have tried this before. But while we're getting it up, just wanted to say we will kind of be going through the slides and then we can take any questions at the end. But if you have questions while we're talking through these slides, feel free to just like speak out and say them. Totally fine to interrupt.
Do you see the screen?
Yeah, perfect.
Perfect. Okay.
Okay, great. So a lot of the topics that we wanted to discuss today kind of fall under the umbrella of pelvic pain. And so that's kind of the broader look at our talk. I think this skipped to the end. Perfect. So just to start off to say there's a lot of different causes of pelvic pain because there's a lot going on in the pelvis. So you've got your bladder, you have some of your intestines, there's muscles and bones, and then there's also reproductive organs. And the pain that people can feel in that can come from a lot of different places. So some examples of that are things like infections, pains related to pregnancy, a twisting of the ovaries, which is called ovarian torsion, cysts on your ovaries, cramping with periods, fibroids, endometriosis, and then, of course, the thing that people are the most worried about, usually cancers, which is an uncommon cause of pelvic pain. One of the most common causes, and usually if you go into the doctor and you're having some pelvic discomfort, one of the first things that you will get questions about or be worked up for is something called vaginitis. So this is an inflammation of the vagina, and it's usually caused by an increase in discharge, which is something that people will notice, and it can lead to discomfort. Usually, like I was saying, one of the first things that you'll get tested for if you come in with a complaint like this. And it's most commonly caused by three things: yeast infection, bacterial vaginosis, or trichomoniasis. And usually when you come in, we will also do some tests for some other things like STIs, like gonorrhea and chlamydia. Excuse me. And I just wanted to briefly go over the three most common causes of vaginitis. Yeast infections is something that people are usually pretty familiar with. Yeast infections are caused by an overgrowth of the fungus Candida, which can be found in lower amounts as regular kind of vaginal flora. With yeast infections, you'll often have thick white discharge, and there will be a lot of irritation to the surrounding tissue that can cause like red skin, and it's very itchy. And that's usually one of the most bothersome symptoms that people will experience. And yeast infection can be treated with an antifungal. Bacterial vaginosis, or BV, is caused by an overgrowth of normal vaginal bacteria. And this discharge is usually a little different. It could be thinner and gray. And one of the most bothersome symptoms with bacterial vaginosis is kind of a foul smell and a bad odor. And that is one of the things that people will often complain of the most. And this is easily treated with antibiotics. And then the last thing, which is less common, but still one of the more common causes, is trichomoniasis, or trick is sometimes referred to as. And trick is an STI, and the discharge with this will be kind of greenish yellow, and it can cause itching or burning around the vagina, as well as lower abdominal pain and pain with sex. And this can be treated with antibiotics. All of these things, when you go to the doctor, someone will do an exam to see what things look like, and then also they can be tested for with just a swab, and that we send out to the lab. And this is often a place that we'll start. But then we also want to talk about some of the other causes of pelvic pain.
Let's dive into fibroids next. Fibroids are a very common word that gets thrown around when people talk about pelvic pain. And I think it's helpful to people because they can point to one thing that's causing their pain, and it's something pretty understandable, like just a lump of cells where they shouldn't be. And they are very common, so that's why a lot of people might talk about them or have them. They are cells that are not going to cause cancer or other problems for your whole body, but they are cells that grow in your uterus where they shouldn't be. And they can grow in different parts of the uterus. So you can see here, there's this fibroid inside the wall of the uterus that's called an intramural fibroid. There's one that kind of grows on the outside edge of the fibroid of the uterus, and that's a subserosal fibroid. And then these two kinds are attached to the uterus through a little stalk, so that's why it's called pedunculated. Just a fancy word for suspended part of the uterus. So they're more common as you get older, and they can be in all sizes, but people might not notice them, or people might have a lot of symptoms from them. Fibroids are not we're not sure why they happen, which is kind of frustrating for people who want to not have fibroids in the future or might already have fibroids and not want to develop them later on. But we think that they're related to having your first period early. And that's because you'll have more of those hormone cycles in your body throughout your lifetime if you have your first period early. Also, possibly related to obesity. Actually, fat cells make more of a hormone called estrogen, and that can perhaps lead to more fibroids or more other problems with menstruation and with uterine related problems. Maybe also alcohol and red meats. We've linked these to abnormal cell growths in other parts of the body. So maybe this exposure or like drinking too much alcohol, eating a lot of red meat also leads to developing fibroids in the uterus. Low vitamin D, and then high blood pressure, which has a lot of other consequences as well. Other possible links, but less likely causes are having more pregnancies, and that also could be related to hormone shifts throughout pregnancy, but the evidence for that is not as strong. And then some types of birth control, like the birth control shot, but again, the evidence is not super convincing for those. Your doctor may tell you that this is a possibility if you're considering some types of birth control, but it's not a reason that anyone would tell you not to get on this type of birth control. Okay, some of the symptoms for fibroids are listed here. And as you can see, reading through them, they're very broad symptoms. So it could be heavy or prolonged periods. That's more than a few days of menstrual bleeding. It could be pain with sex, could be feeling a lot of pelvic pressure or some fullness in your pelvic region too. Perhaps even difficulty emptying your bladder because the fibroid is big enough that it's causing problems urinating or peeing. And then also constipation, where the fibroids are big enough that they're then compressing or filling too much space where you would need to poop. And then it can also cause pregnancy complications, especially for those fibroids that are inside the wall of the uterus that we were looking at earlier. And then the diagnosis can be tricky for people with fibroids because the most common causes are that prolonged bleeding, like having a heavy or a really long menstrual cycle, and then also pelvic pressure, which is not always a very specific symptom or not something that points directly to one thing. So we need to rule out pregnancy and other causes of abnormal periods first. And your doctor will probably also recommend doing a pelvic exam where it's like a speculum exam, and they might also feel inside your uterus to see how large it is, if there's masses that they can feel, or those lumps that are the fibroids. And then the best way to get diagnosed is a pelvic ultrasound. If you guys have been pregnant and had pregnancy dating before, it's a similar process where they would put the probe inside your vagina and look around to see if there are fibroids there. And then your doctor may also recommend a hysteroscopy, which is a little bit more involved in that you would have a camera inside your uterus to see totally around it. Fibroids, like we mentioned earlier, are not cancerous, and they are not made of cells that could become cancer. There are some types of collections of cells that are leiomyosarcomas, which are not called fibroids in the way we normally talk about them, but usually fibroids are very normal and benign, so they won't cause cancer. And it also doesn't increase your risk of having other types of cancers if you have fibroids. And the treatment for fibroids is usually watch and wait. So a lot of fibroids shrink on their own. They can get smaller in the next few months or the next few years. And then also after having a baby, there again are a lot of changes in your body and with your hormone levels. So the uterus can shrink back down and sometimes reabsorb the fibroids or go away. during that shrinking period. And during menopause, often fibroids shrink on their own as well due to the lower hormone levels, unless you're taking a hormone replacement like estrogen and progesterone during that time. The definitive treatment for fibroids, if you don't want to just watch and wait, is have surgery. And you might have heard that people have their whole uterus taken out because they have big fibroids. Well, that might be the case like 10, 20 years ago, but now there's a lot of other options, and that can actually spare people having a big surgery where they remove the whole uterus. So the most common one is called a myomectomy, which is a surgery that just removes the fibroids, those little lumps inside the uterus, without taking out the rest of the healthy tissue around. They can also do endometrial ablation, which is helping with the symptoms of fibroids, like heavy bleeding. And that would be targeting the lining around the uterus, not just the fibroids, so that you don't bleed as much during your periods. There's also something called myolysis, which is like lysing or destroying the cells in the fibroids. And this is a very fancy, newer option. And then there are also ways to target the blood flow to the fibroids called uterine fibroid embolization or uterine artery embolization. And the last and most involved surgery is a hysterectomy, which removes the whole uterus. And this is the only sure way that you won't have fibroids again. But usually, because this is such an involved surgery, we don't recommend it for most people. We recommend it only if there are very large fibroids, if the bleeding is really heavy and not controlled, or even with medications, or if you don't want any more children. And then I saw a question in the chat. Someone was commenting that they're 30 years old and a mother of a child. Period comes on time, but it seems heavy and dark brown in color on the first day and second. Yeah, so thank you for your comment. That is definitely something that a lot of our patients notice as well. And I would say that you should talk to your doctor about how heavy your period is. A normal amount of blood flow would be less than having like 2 changes of your tampon or pad in an hour. So if you're noticing that your flow is really heavy and you're needing to change that super often in the first 1 or 2 days, then that's something to talk to your doctor about and maybe get some of this testing and get some of the workup for fibroids or other things we'll talk about. Here's just some other information about fibroids. A lot of like national centers and societies have information on their websites, so you can always look these up or call some phone numbers for more information.
Okay, now we can talk about another cause of pelvic pain, which is endometriosis. Endometriosis is a type of tissue that lines the uterus, and it's basically a specialized part of the uterus that can grow in response to hormones, including estrogen and progesterone. They can occur when the tissue grows outside. So if you notice here, this basically the tissue in here called endometriosis. And if this tissue will kind of travel for some reason outside, like here or somewhere around here, they can cause, they continue to grow, and they can cause issues and pain. They can grow on the side of your bladder, sometimes in the lining of the intestine that called peritoneum, and the ligament around the uterus and vagina. We still don't really know why this happens and why these can kind of travel anywhere else, but it usually is the most common to happen in ages between 25 to 35. Oops. I'm sorry, I don't know how to remove these, but anyway, uh, let me see if I can get rid of them. Yep.
Sorry, I realized I was on mute. Why don't you figure that out and I can answer the questions in the chat?
Love that.
Okay, so for fibroids, the regrowth is a really good question. I'm not sure actually the rates of regrowing fibroids, and maybe some of my colleagues will have that information in their heads already. But if you have small ones, then you could get multiple, but again, they could go away within a few months or a few years. And then I am not very knowledgeable about the myolysis. That's a pretty new procedure, no, from my knowledge. So I think that they would go through the vaginal cavity into the uterus again, like they do that for the uterine artery embolization as well. And the most effective one for like never having fibroids again is the hysterectomy, because then you just don't have that tissue where the fibroids would grow. But for each person, the surgeon who does this, which would be a obstetric and gynecological surgeon, would talk to people about their risks and the best surgery for them. Like if you have small fibroids, you probably don't need a whole hysterectomy, but if you have larger ones, then that might be more effective and just more problem solving for you. And then if you have a little small fibroid, it is not a reason for you not to get pregnant. That's a great question too, because a lot of people can get concerned if they see on an ultrasound or like they're going in for their first prenatal ultrasound, and they see a fibroid. That's not a reason to stop a pregnancy at all. Sometimes if a fibroid is big, then your doctor might talk to you about the fact that your contractions when you're delivering the baby might not be as strong, or you might have some issues where the baby can't be, like it gets stuck because of where the fibroid is, but that's still totally fine and manageable, and people have babies who have fibroids all the time. But I understand that that is something that you might not know, like you might not have talked to your doctor about yet. So it's a great question to bring up also during those doctor visits. And you definitely don't need to take them out to get pregnant. Or when you're pregnant, you don't need to get a surgery to take it out. And usually we wouldn't recommend that anyways, because you're already kind of having something disrupting the uterus by being pregnant. So you don't need to do another surgery or procedure that might also interfere with your uterus at that time. And people can safely have pregnancies and have babies when they have small fibroids. Okay,
Thank
great
you.
questions though. And Shireen, please add anything else you wanted to add to that too.
No, I think those are great questions. Thanks for your participation. We would love those. Um, and yeah, Dr. Chen, I have nothing else to add. That was great. So going back to endometriosis, as I mentioned, we don't really know what is the reasoning for those growth outside of your of the lining of the uterus, but they mostly happen in ages between 25 to 35. Endometriosis has some symptoms as specific as pelvic pain, as we already talked about. There are multiple reasons for those pelvic pain. However, sometimes with endometriosis, the pain with periods are more pronounced. Sometimes it depends on where the growth is. Sometimes can be pain with sex. Sometimes these pains can be crampy or dull pain that starts before periods and usually lasts throughout the period and a little bit longer. Some things that are kind of frequently heard is that when while you have your period, bladder emptying, peeing, and pooping sometimes can be really painful. and sometimes increase the urination frequency, and sometimes it can cause diarrhea or constipation. In terms of how this diagnosis can affect the fertility and the ability to get pregnant, there's not specific detail about it, but some research has shown that 1 or 2 people that have infertility, like inability to get pregnant, they also have endometriosis. Um, in terms of the diagnosis, it's very difficult to diagnose endometriosis because, first of all, there are a lot of other causes that are more common to cause pelvic pain. And we usually start off by doing other workup to exclude other reasons like infection, fibroids, or other things. And then if there are no other reason for that, then the next thing could be an ultrasound of the ovaries that can sometimes look like endometrial tissue. And the definite diagnosis for endometriosis is actually doing a biopsy. And basically, a surgeon will go inside and take a sample of that growth, wherever it is, and they look at it under the microscope. And then that would gives them the sense, is that the same tissue as the lining of your uterus to be diagnosed as endometriosis. And if there is an ongoing pelvic pain without any other causes, and it's caused severe symptoms and it does not respond to any medication or any treatment, sometimes the doctor might recommend doing the biopsy for a definitive diagnosis. In terms of the treatment so far, if the symptoms are mild to moderate pain and there's no ultrasound findings for other things, and says like Advil, ibuprofen could really help. You sometimes can take hormonal pill, like contraceptive pills, for also known as birth control pills. They can also help that. Other methods of contraception are implants or IUDs, intrauterine devices that actually release progesterone. There are 2 types so far that we have. There are IUDs and implants like Nexplanon, you probably have heard, that goes inside, like underneath of the skin on the arm. If there are severe symptoms and they're not really responding to the pain medication or the hormonal pills, sometimes we can consider a medication that called GnRH analog. It's basically a gonadotropin releasing hormone. It's basically a hormone that is released in our brain and is responsible for kind of maintaining the production of other hormones like estrogen, progesterone, and all this stuff. And that could decrease the growth of estrogen, that decrease the growth of those tissues that are other places. And even if that is not a relief, adding aromatase inhibitors, which also is another name for a medication that basically stops the body from producing estrogen in fat cells, as Dr. Chen was mentioning, because estrogen in fat cells, like obesity or having a lot of fat cells in our body, they actually increase the growth and production of the estrogen. And adding an aromatase inhibitor can stop production of those fat cells for estrogen. And if none of those are working, then we go to the last diagnostic and treatment option, which is a laparoscopy surgery. Basically, they will do little small holes through your umbilical like belly button, and they basically go inside with camera and will take a sample of that and to look at it under the microscope for the definite diagnoses. Before we go, trying to figure out if there's any question in the chat.
Doctor, I just had a question. I wrote it in the chat, but besides laparoscopy, are there other imagings that are done that are not as invasive, obviously, but that can show you guys close, like if that is endometriosis for sure?
That's a great question, and the answer is unfortunately no. And that is the kind of downside of this, that the only way we could see, there's sometimes we can notice that there is a growth or something that are visible with ultrasound. But then for a definite diagnosis, we still need to kind of get a sample, which is an invasive treatment. And to clarify, one or two people, like in terms of infertility and the difficulty with pregnancy, as I mentioned, there's not still like a definite evidence and research on how this can cause infertility, but on studying of people who had difficulty pregnancy, like getting pregnant, there has shown that one or two people had a history of endometriosis. So I know it might be a little bit confusing, but please let me know if it still didn't kind of answer the questions. And yeah, I'm gonna pass it to Dr. Goldman.
Great. All right. So the kind of last topic that we wanted to touch upon was ovarian cysts. So ovarian cysts, just briefly. So what we have, the picture that we have on the left side of the screen is a uterus, and the little cloud-like structures are ovaries, and that's where eggs are held and released every month. And then you can see a drawing of an ovarian cyst on this right side. So ovarian cysts are usually fluid-filled sacs that develop on the ovary. The vast majority of the time, they are totally benign, which means that they're not cancer. Some common causes of cysts, the most common cause is something called a functional cyst, which is part of the normal menstrual cycle for people, that your ovaries will develop cysts like this. And usually with functional cysts, they can cause some pain and discomfort, but a lot of the time we'll see them on ultrasounds when you're getting an ultrasound for something totally different. And it's called an incidental finding, which means that there were no symptoms from it, but it's noted on the imaging. That being said, they still sometimes can cause discomfort, pelvic discomfort. Endometriosis can also is also associated with special types of cysts. There's something called a dermoid cyst, which is a cyst that grows from a kind of special type of cell. And these are pretty cool. Usually dermoid cysts are totally benign. But one of the cool things about them is that because of the type of cell that they grow from, they can sometimes actually have hair or like teeth in them, which is kind of interesting. There's something called PCOS, which is polycystic ovarian syndrome, which is where some people will have just many smaller cysts throughout their ovaries. And then rarely you could see like ovarian cancer as a cause. So some symptoms of ovarian cysts, like I was saying before, many of them are completely asymptomatic. The most common symptom, if you are feeling it, is pain or pressure on one side of your lower belly. Descriptions of what the pain feels like can vary. It might be more persistent or it might come and go. Sometimes it can be sharp or dull. Sometimes the cyst will break open or rupture, and that can be associated with a sudden sharp pain, especially if they're larger and there's more fluid in them. And it's kind of funny sometimes to think about the fluid in the cyst kind of just being in your body, but it is just reabsorbed by your body after it bursts. The cysts themselves are not associated with abnormal bleeding or periods. which is one of the differences between this and something like fibroids. So diagnosis of cysts. Usually this is done with imaging. As you can see, so much of the diagnosis that we do with this sort of stuff starts off with an ultrasound, partly because it's a really great test that is can be uncomfortable, but doesn't carry any of the like long-term risks of radiation that can come with other tests. So it's a really, really safe option that we like to utilize first. With the ultrasound, whoever is reading it will look for different characteristics of the cyst and what it looks like kind of on the inside of the cyst. And that can point to if the cyst is more benign or if it might need more follow-up. Usually, the cysts are benign and no follow-up is needed after that. But sometimes if they can't absolutely say if it's benign, they might recommend getting a repeat ultrasound that's usually done about 6 weeks later to compare the size and the shape of the cyst to see if it's growing or changing. And that can help decide if this is something that one maybe went away on its own or is shrinking on its own and doesn't need further follow-up, or might need more follow-up later. Rarely the imaging can show markers that could be concerning for like a more worrisome thing, like some sort of ovarian cancer. And when that is the case, then your doctor might have you get labs. And some blood work can look for like markers of ovarian cancer. And so that's why they would have you get the lab work done. But I will say, like, all of these things are sometimes things, but the vast majority of the time, they don't need that much follow-up, or they need an ultrasound in a couple of weeks, and we can be reassured by that afterwards. For treatment for ovarian cysts, the most common type of treatment is just time, and these are things that will go away on their own. Your symptoms can be monitored by yourself and by your doctor, and most of the time the cyst will resolve. Sometimes you can use things like birth control pills to help regulate the development of new cysts by regulating the hormones in your body. And then if there's any concern for cancer, if there are really persistent painful symptoms, or if there's a very large cyst, and an OBGYN surgeon may consider a surgical removal for these. One of the concerns with a very large cyst, I will say, is that sometimes the cysts can put you at risk of something called ovarian torsion, which is when your ovary will kind of twist around its stalk, and that can restrict the blood flow to it. And that is really, really very painful and is more of an emergency. So if you suddenly get really, really sharp pain to your lower abdomen, these are all things that we would want you to go see someone to get treatment and to get worked up for. And then the last thing that we included is a example of a tracker. If you're having kind of recurrent pelvic pain, or if you want to just keep track of what symptoms you're experiencing, this is an example of a calendar over a month and some examples of different symptoms that you can have on the left there. And this can be really helpful for you to find patterns for amount of bleeding or nausea or pain, if you're having any GI symptoms with it. It can be helpful for you to kind of keep track of, but it can also be helpful to go over with a doctor if it's something that you would like to talk about at one of your medical appointments. And those are all of our slides. Let's look through the chat.
I have a question, a great question about endometriosis. The question is that I have same symptoms of endometriosis that we mentioned, and they have done ultrasound, but the doctor didn't specifically mention that they might have endometriosis. Does that mean that we need to do more imaging or not? As we mentioned, the first imaging modality that would be most useful would be a transvaginal ultrasound, meaning that the ultrasound probe will go inside the vagina to have a better, closer look around the ovaries and the uterus lining. But then it's not a definite diagnosis, and sometimes the tissue might not really show up. And even if they see some tissue, it doesn't necessarily mean that it's endometriosis. And unfortunately, if you persistently have those symptoms like pelvic pain that are not related to infection or any other things that we just talked about, if you have pain with sex, if you have pain with pooping while having a period, and other those things that are not really responsive to pain medication, then you might need to go back to the doctor and talk further in detail, reporting the specific symptoms that you're experiencing and mentioning that probably like Advil or ibuprofen has not helped, and they may consider further evaluation and considering other medication that we've talked about before kind of definitively diagnose endometriosis, which is only by biopsy and invasive procedures.
And then I'm looking at some other questions. One of them is about how long an ovarian cyst might take to resolve. For those kind of functional cysts, it usually can take weeks to sometimes a couple months. Yeah, I think that the average time is typically like six weeks to the longer periods of being like 3 months. And then I think one of the other questions, and I'm sorry if you answered this, Shireen, was are fibroids hereditary? Which is a really good question. They're not like strictly, just because someone in your family had them doesn't mean that you absolutely will. And just because you have them doesn't mean someone in your family had them before. But there is an association between if there is a strong history of fibroids in your family, you may be more likely to have them. But I don't know what the exact numbers are off the top of my head.
To be honest, I also didn't know the exact number, and based on my quick research, it's apparently multiple studies have demonstrated a significant genetic component to the development of uterine fibroid. For instance, a analysis has shown that some of the risk across why that the uterine fibroids are happening, it actually can be shared by genetic. And if, as Dr. Goldman was mentioning, if you have a family member or someone who are closely related to you that have had fibroids, you might consider mentioning that. And if you have symptoms, you might also have those. Great questions.
And then the question about pain with sex. Typically, so pain with sex, depending on what it is caused by, can mean different things. So sometimes that can mean just like initial penetration, or it can mean deep penetration, depending on the source of what's causing the irritation. Yeah. So it kind of depends, which is not always a helpful answer.
Thank you so much for the questions, guys. I see some coming up, including some of mine. Oh, yeah. Yes,
Yeah.
we'll be sharing out, yeah, and I'll let the doctors respond to that question, but we'll be sharing out the video and the slides from our doctors. They're so kind to share. So you can always refer back to the video and watch the beginning on fibroids. But yeah, go ahead.
And it's a great question about why do Black or brown women have more fibroids. I don't think we necessarily know the reason, but as you also mentioned that the studies have shown that African American women have found to have a more stronger genetic history. So if a maternal history, if the mom had a history of fibroid, there's a significant risk for the offspring, like the children, to also develop that, especially if the mom was diagnosed at a younger age. But unfortunately, I don't really know if there's any kind of evidence behind of why. I'm not sure if Dr. Chen and Dr. Goldman have better information on that.
I would also just add, and I don't know the exact statistics on this, but we had talked previously about how hysterectomies were often used to treat fibroids. And I think that studies have shown that Black women had higher rates of hysterectomies than white women for this, which I think is important to call out because this is not something that we think of as needing a hysterectomy. And so whenever there's disparities in who is getting that really invasive procedure, something that certainly needs to be thought of when we're thinking about this.
Doctor, can I just press a little bit on that? Why do you think that is? Like, why are they offered hysterectomies as opposed to these other interventions more often?
I think, like so many things in medicine, a lot of it comes down to like the fact that racism is deeply embedded in the history of medicine. And I would assume that that is playing a huge role in why it's happening.
Absolutely. Thank you for addressing that.
And then Nadia, did you have a question?
Yes, I have actually 2 or 3 questions about fibroid. Normally a menopausal person with fibroid, normally the fibroid shrink, which is not the case. So I wanted to know why and the relationship between fibroids and the release of estrogen in the body. Like normally menopausal person have less release, less estrogen in a body. So, but fibroid, I heard or I know that fibroid are they grow more. We have more estrogen in a body, more the fibroid grow. So it doesn't make sense for me. This part I don't understand. Like with menopausal person, the fibroid shrink and fibroid grow with the presence of more estrogen. If you can explain more, please. Thank you.
If I'm trying to kind of summarize the question, so I think if I'm understanding it correctly, sometimes we say that after menopause, fibroids are less commonly to develop or grow. And the reason for that is usually fibroids are growing in basically affected by the releasing of the hormone like estrogen. And when we are reaching menopause, those hormones will go down and they are released less compared to before menopause. And that's the kind of thought about it, that there probably will be less growth and there will shrink more often. If that's the question. If not, I'm gonna have Wendy to kind of better kind of explain that. Or Rebecca, if they're still available.
Sorry, I missed a little bit of that because I was gonna respond to a question in the chat. But Nadia, did that answer your question?
Yeah, a little bit. Oh, normally the body, when we age, the body release less estrogen. Is that true?
Yeah, that is correct.
But at the same time, I heard that the fibroid are growing uh, because of the estrogen. So in my case, I am menopausal, but my fibroid are not shrinking, they're growing. So how can that explain that I have more estrogen in my body that they are growing?
I don't know if I can say exactly why that's happening for you. I'm sorry that that's happening. I'm sure that's uncomfortable. And I think usually when we are talking about these broader ideas of like sometimes fibroids can shrink when you are going through menopause. Unfortunately, they are not always true for individuals, and that's not something that we can make like a statement for everyone about. And I don't know if I could say exactly why your fibroids are not shrinking or going away. Sometimes, and I'm not sure if this is the case for you, sometimes when people are going through menopause, we'll do something like hormone treatment to help with menopause symptoms, and that can certainly influence it. Yeah. I'm sorry that I don't have an exact answer to your question, though.
Yeah, thank you.
And then to answer the question in the chat, what do you wish more people from underrepresented backgrounds knew when walking into a gynecological office? And I would say I think this is true for every office that you walk into. Sometimes when you go to the doctor, you will have short appointments, and sometimes it feels like there's not a lot of time to have a full discussion or have everything explained to you. And I think the most important thing that you can do if there is any sort of confusion or if you don't feel comfortable with something, is to recognize that the vast majority of the time, you don't need to make decisions that exact same day. And if you have questions, that it is totally fine to say, I would like to have another opportunity to go through more of these questions with you. And sometimes that means another appointment. Sometimes that might mean a phone call later. But I would love if everybody could leave every appointment feeling like they are not confused. And they're not kind of unsure about what's going on. So I think the most important thing is to ask all of the questions that you have. And if that means that you need more time, then it means you need more time.
Doctor, just to follow up on that, for as you mentioned, like our current healthcare system is not really, it's like 15 minutes. Yeah, you're allowed and you can only discuss one thing. And for people of color or marginalized communities, I've heard from family members accounts of like my doctor won't even come near me or touch me. They're being dismissed, like, ignored. In that like situation where the patient feels powerless, what do you as a physician like suggest that they do? How can they advocate for themselves more? I mean, and some of them do have language barriers as well. So how do you go about that kind of situation?
Gosh, that's so hard. And
Yeah.
I'm sorry that anyone is experiencing that. That's really awful. I think
I can
Can I
add
help
one
with
thing,
that?
if that's okay.
yeah, go ahead, Rebecca.
I think at our clinic, like Shireen and I work at a clinic that serves a lot of people who might be also having language barriers or like barriers to accessing care. And it is frustrating to have those appointments where you're only allowed 15, 20 minutes to talk to someone and they have questions that you can't fully address. And I think it's actually really helpful and empowering when people bring family members who can speak for them and with them to say, this is also what I've noticed, and this person, like maybe the patient feels like they don't want to take up more time, or they don't want to talk about all of their symptoms, but then the family member can say, hey, actually they're in a lot of pain and they're suffering every month, and they can be that other advocate for the person too. Or a friend, it doesn't have to be like your immediate relative, just anyone to help you with questions that you still have, or speak up for you if you feel like your symptoms are really bothersome, or what you're experiencing is worth talking about more.
And what if like the doctor refuses to send you for tests? Because I mean, even though you're in pain, but they're like, oh, it's fine. It should clear up within a few days. Just do this. But you clearly are wanting like some sort of tests done. So can patients insist on that? Is there like, could you not push back, or are we allowed to, and to what extent?
I also wanted to say, as a person of color, who is also English as second language, I absolutely hear that, and I feel that. I've been there. And it's very uncomfortable to experience that. I'm sorry. And to be honest, we still experience that every day. It's very unfortunate, but that's the reality. I have to admit that and acknowledge that. That's a great question. I think as we are now also residents and going through training, in terms of why doctors are not very approaching patients, despite their color, despite their who they're coming or where they're coming from, is basically there is a kind of relationship boundaries that we also train to have. So it's sometimes we are also responsible for how we kind of approach patients. So that might be one factor from doctors. And the other thing is I totally understand when we are in pain and we feel like we're not being heard. Sometimes, as we already talked about, just a few things that are not definite diagnoses, and actually the first or second or maybe the third step into diagnoses is time, pain management, and less invasive procedures. Although it may feels like that we're trying to avoid or we're trying to minimize the pain. This is not specifically the case. It's sometimes there are limitation in medicine and our diagnostic tools that and also the study and everything, that we don't necessarily have the best diagnostic tools that are non-invasive and are not very risky to our patients. And our first responsibility is to decrease the risk and prevent harm. And sometimes with time, some diagnoses could show themselves better and either resolve without having any invasive or further labs that can cause increase the risk, increase the financial burden, and all the things that could be prevented with further time. And sometimes also knowing this would sometimes help us to better kind of approach that situation. So that's what I would also add.
Thank you, doctors.
I think Nadia still has a question, if that's still the case.
Yes. I have a question about fibroid also, and the relationship between fibroids and the low vitamin D. I saw in your presentation that there is one of the causes of fibroids are low vitamin D and high blood pressure. My question is like in one of the videos of Dr. Eric Berg, he was talking about to shrink fibroids to administer a high dosage of vitamin D and K2. And well, it's hard to believe, but some comments after his video, some people comment that it's really they follow, I don't know how many dosage, but it's high everyday dosage of vitamin D and K2 may shrink fibroid. And some people, they even had the big fibroid in the size, but when after not a long time, like few months, the following his taking the intake of vitamin D and K2 every day in high dosage, and their fibroid shrink, and they avoid to have a hysterectomy. So what can you say about that? I don't know if you heard about that. And I know that administering vitamin D in high dosage can cause a lot of trouble to the arteries, and that's why he balanced it with the K2. So what do you think about the vitamin D for shrinking fibroids? And I don't know if you heard about the Dr. Eric Bird uh, video and
I
about fibroids. Yeah.
Yeah, I haven't heard of this doctor, but I am generally telling patients that if someone promises you something to fix all your problems, they don't have the solution, because they can say that they have all this new science and that they have this method to doing things, but if it's just something that they are doing on their own without much evidence or data and proven trials to help, then they might just be wanting you to pay for something that doesn't actually help out. And that is unfortunate because, this is a very, very pressing issue and something that causes problems for a lot of people. But there isn't much studied about vitamin D treatment for fibroids. So far, there's just been studies that show that if you have insufficient levels of vitamin D, then you might have more, you might be more likely to have fibroids, but people haven't been trialing or having much success in using vitamin D to shrink fibroids. So it is unfortunate because people can kind of peddle these things or market these things as cures, but they're not maybe evidence-based, and they're not things that we are giving people because it might cause more problems, like you were saying, with the high doses of vitamin D being unhealthy for people. So I think it's good to keep looking for new things, but also keep in your mind that not everyone has a cure, and if they do have something that seems too good to be true, it might be.
Yeah, thank you.
I also just found a study about this great question, Nadia. It's a very educational for me as well. And it's a kind of study that has been kind of showing about this. And yeah, it's a nice read if you would like to read it. And it's absolutely mentioned what Dr. Chen was mentioning. It has shown, but it has not been any human trial that actually shows any specific data. But great questions.
Dr. Shireen, could you share that out with the slides later, please? So I can send it out to people. Thank you.
I just put it in a chat if that's helpful. And regarding the question about non-surgical ways to shrink fibroids, as we mentioned, there are hormonal options to prevent increase in estrogen release, which is the main driver to increase the fibroids sometimes. And those are the first steps to try, like hormonal birth control, and those are the first things to try. Usually surgical evaluations are mostly kind of remains the last resort for fibroids that are either complex or they're preventing or like causing issues, but usually surgical options remains to the kind of last resort. And in terms of if the surgery can affect further pregnancy, it is absolutely yes, because any scar into your uterine wall can kind of cause complication with pregnancy, not necessarily preventing you from getting pregnant, but the scar can cause issues and complication with pregnancy. And that is why we try to avoid any surgical and any invasive intervention in terms of the uterine, like in terms of the uterus, especially if you're in that childbearing age and you would like to get pregnant, because any invasive procedures can later on complicate pregnancies.
Does that include the myelitis, sorry, or is that just the embolization of the, like, which ones kind of put you, like, you won't be able to get pregnant if you have of the procedures?
It's, sorry if I missaid it. It's not that you won't be able to get pregnant.
Oh, okay.
It's the complication that can arises during the pregnancy because of the placement of the placenta, because of the scar. In terms of if you would like to proceed with vaginal delivery, that might prevent that. So those are the complication, not necessarily preventing pregnancy.
Oh, and the complication with most of the procedures, or just some of them that you mentioned?
Any procedure that can cause a
Mm.
scar to the uterus and inside of the uterus lining that can, the scar basically can cause problems.
Mhm.
And that's not to say that every pregnancy will be affected. I would say that this would be like a great question to talk to the surgeon if you're going to get a procedure about, because it depends on how much of the uterine wall is affected by the surgery, which can be which can depend on fibroid placement and how big the fibroid is. And so I would say there's a lot of variety in risks after this. And so definitely something to have a in-depth conversation with whichever surgeon you're seeing for it.
Such great questions, guys. Thank you so much. The doctors, I think I have one of mine that was not answered, but another one just came to mind. Can you tell us what retrograde menstruation is? Is that when your period goes back into your, like, uterus, or?
I can take it.
And that came up, so I didn't know what that meant. Yeah.
It's when the when the tissue goes back up through the fallopian tubes.
Okay.
Um,
Mhm.
yeah.
Tissue, the tissue, not the blood.
The blood is like as the tissue lining.
Mm-hmm.
Yeah. So sorry, I'm using those terms
Yeah.
interchangeably.
Yeah. And does that happen like a certain position when you're lying down or when you're standing, or does that matter?
I actually don't know the definitive answer to that. I would expect not.
Yeah.
But I'm not entirely sure why it happens sometimes.
Okay, thank you.
Yeah.
And I think my other question was, are there things that we can do to sort of mitigate like the pain or lessen or minimize the symptoms of any of these conditions, like being proactive?
I think the things that we'll always start off with is things like Tylenol and ibuprofen for one. I think sometimes we think of them because you can get them without a prescription from a doctor. We don't always think of them as like the best pain medications, but they're actually really wonderful pain medications. And those can be definitely used. Things like heat can be used with cramping, so a hot pack and things like that. And then also, with a lot of these conditions, things like IUDs or birth control pills can help with the like hormone balances, and those can help with symptoms like bleeding and also the significant like cramping pain that you could get with a period.
And any dietary changes?
I I would say always like increasing the amount of fiber that you're intaking can help regulate your stools. And if that is one of the things that is affected, that's always a recommendation. Rebecca, I don't know if you had something else.
I was just going to say that there's a lot on the internet about like PCOS diets or things for cystic ovaries, and there's a great endocrinologist that we work with, so someone who studies the hormones and has years of experience with that, and she doesn't think that any of those diets are really effective. There's again not very much evidence for it, but in general, eating whole foods, eating fiber and like grains and vegetables will be healthy for everyone.
So if you're having like cravings before your period, does that like chocolate, things like that, they don't make the symptoms more more like, I don't know, worse?
No, food shouldn't affect it too much. And
Okay.
I, for one, am always a fan of chocolate
Yes.
for all the pregnant
Yes.
pre-menopause things.
Yeah. Awesome. Anything else?
I would also add, because some of those pain can be caused by increased inflammation, avoiding the foods that can cause inflammation, like processed food, added sugar, some of those things can actually increase the inflammation and further increase the pain. And that could also help a little bit. Also, anecdotally, some kind of food that can cause bloating that can also increase the pain could be avoided to kind of minimize the pain and discomfort.
Thank you, doctor. Yeah, I like the idea of hormones. Maybe we can have a session on just hormones, because I know they kind of like dictate everything that basically goes on in our bodies. So yeah,
Yeah,
so
I think that's a great idea.
cool. Are there any more questions, guys, comments? You've been so great with your questions. Thank you so much for asking them. Really appreciate them. And thank you to our doctors for an awesome presentation and for answering all of our questions. And we will share the slides with our members, and then I will upload the video to our YouTube channel, and you guys can watch it there as well. Thank you so much, Hanan. Okay, if there are no more questions, I will go ahead and end our session. And thank you, doctors, for coming, and thank you to our community for being here today and so asking your questions. We will see you guys for another great session. Thank you, guys.
Thanks everyone
Thank
for
you very
coming.
much.
Thank you.
Thank you.
Yeah. Bye.